Thanks, Daryl. So when I was given this topic, I was thinking about what this really means, when to refer, and I thought about it in two different ways. One could be when in the timeline of this patient's pathology, and when in your experience with that type of pathology do you want to refer this patient on. So just like Zia was explaining, there's 4 different compartments I really think about these tumors: in primary tumors, metastatic tumors, intradural tumors, then peripheral nerve type tumors. And I'm going to focus mostly on primary tumors because that's really where we get in this conundrum of when to refer. So yesterday, I didn't see it, but I bet it was great because I've seen it before. Dan Schubert gave a talk on primary tumors of the spine and talked about the pathology and how we treat them. And when you think about when you want to refer somebody for something like this along the timeline of that treatment or along your ability set, really you're thinking about the primary tumors. And Zia pointed out the chondrosarcomas and the chordomas. Those are primary tumors that are stereotypical, that we know that there's really nothing else that other people can offer besides ourselves from a treatment perspective. So surgical en bloc resection is the treatment of choice for those. But when we start to dig into these other primary tumors like aneurysmal bone cysts, giant cell tumors, even atypical hemangiomas, and then our sarcomas, that's when you need a small village to really treat these patients, really understand what the pathology you're getting into. And so for these patients with primary tumors, understanding the pathology of what you're getting into is very important. So when to refer in that timeline of things is really when you know what you're dealing with. So for me, the most important thing to start with is the biopsy and understand what you're getting, right? And depending on where you are, depending how good your pathologist is, and more importantly, well, I don't know, equally importantly, how good your neuroradiologist is to get this biopsy is really going to be the first determinant of when to refer the patient. So if you're in a place that doesn't have a neuroradiologist that's going to get a good sample of tissue safely without contaminating everything, or pathology that's not going to mess up the tissue and not going to give you a diagnosis, you should probably send them even before you get the biopsy. But if you have that quality in your hospital, then you can do that as well. Once you figure out what the pathology is, then you determine, do I have what it needs from a whole systems-wide treatment perspective to take care of this patient, right? And I'll take you through a few examples. Looking through just my experience with tumors, I think everybody has their own referral pattern, so I'm not sure this really represents how tumors are referred to you, or what the common tumors are in a practice, but in a primary tumor practice, the majority of these tumors are going to be sarcomas and chordomas, and less likely these other tumors. Where do they reside? Well, in my experience, the majority of them are in the sacrum, but they reside throughout the spine. Cervical spine is the least common, but it does happen quite a bit. So I'll take you through a few cases and how I think about these and what it takes when you're thinking about these cases to do the case and pull them off, right? So this is a patient that's 65 years old, comes in with a tumor that's involving C2, C3, and C4. You can see there's epidural extension that's involved in the vertebral body. It's surrounding the vertebral artery on the right-hand side. CT guided biopsy demonstrates this to be a chondrosarcoma, and CT chest and pelvis is negative for any sort of metastatic disease. So with this pathology, the treatment of choice would be en bloc resection. How we used to approach something like this would be an anterior approach with a transmandibular extension, tracheostomy, PEG, and then following up with the posterior approach. And this, after evolution of these sort of things, we can try to narrow a treatment approach to them, sort of minimizing their morbidity. So with an anterior approach, moving the esophagus out of the way, dissecting all the way up to C1, and then performing a very radical discectomy at C3-4, taking out the annulus, preparing everything for resecting this, and also unroofing the vertebral artery on that left-hand side. Following that, we'd go posteriorly with the exposure with an occipital cervical instrument infusion, complete the osteotomies on the side of the vert that we're going to protect, sacrifice the vert on the other side that it's going to be disappearing from, and then because the specimen is so large and so posterior locally, we can actually rotate that specimen from anterior to posterior and deliver it all through the back, avoiding that whole transmandibular approach. That also requires cutting an odontoid from the back, which can be done if the vertebral artery has been sacrificed on that side, with a posterior reconstruction, very similar to what Zia was showing in that other slide as well. So that's what one primary tumor, and that's the reconstruction. That's what the post-op looks like, and there's a specimen with everything. Similar tumor appearance, again, biopsy first, chordoma. Similar type of approach. This is going a little bit higher, involving a little bit more. So this is actually going up involving C2 and C3, but approaching the vertebral artery all the way up in C2. So you're going to have to cut above C2 in the C1 lateral mass. Very similar type of approach, anterior first, then posterior. And this is the specimen that you see where you can see the C2 and C3 vertebral bodies. They're cut down a little bit off towards one side because the tumor didn't involve the entire vertebral body. It was more eccentric to one side, so you have a little bit more leeway with your anterior osteotomies. The vertebral artery had to be sacrificed above the arch of C1, and the arch of C1 is cut right in half along with the lateral mass of C1, which I'm not sure how to point on this thing, which if you look at this picture, this is actually C1 lateral mass with the anterior arch of C1 here with the top of the odontoid and the vertebral artery right here. So in order to get that specimen out, that's what you need to do. And that's what the post-op looks like. Similar looking tumor, 32-year-old gentleman comes in, neurologically pretty good, although he does have a little bit of myelopathy. This CT guided biopsy shows Ewing sarcoma. Well, years ago, before my time, surgery was the treatment of choice, but it was a bad treatment of choice. Now with chemotherapies and the way they are, that's now their treatment of choice first. So this person with the Ewing sarcoma diagnosis would undergo chemotherapy first, possibly neoadjuvant radiation therapy, and if there was no site of other disease after all that, then consideration for en bloc resection. And that's what happened with this patient. So 6 months after having vincristine, doxorubicin, cyclophosphamide, and then ifosfamide and etoposide, the tumor has shrunk. It's now something that is resectable. Then the debate is, do you do neoadjuvant radiation or not? And then you have to understand what's going to be involved in your radiation, with your surgical care if they've had radiation, or what's going to be involved in your postoperative treatment with radiation if you've done surgery. So in this patient, we elected to have surgery first prior to radiation just because the planes would be less disrupted. We'd save that vertebral artery on the one side, and so this resection involved the vertebral body of C3 plus the posterior elements all in one piece, sort of same sort of thing with anterior and posterior type of approach. Now another type of case, here you see this is a 17-year-old gentleman with the MRI scan with a very characteristic sort of fluid levels, very different than the other tumors. Again, CT guided biopsy shows now aneurysmal bone cyst, totally different type of tumor. Well, our evolution of understanding these tumors has changed over time. So what we used to think of is, okay, let's just go intralesionally and fight to get this thing all out. Well, maybe we can treat this differently. So Boriani and his team worked on this with aneurysmal bone cysts and found that with calcitonin and steroid injections directly into the tumor, over time they can get these things to shrink. So in my practice, that's what I would try first, and as long as they're neurologically staying okay, I will keep trying this. I tried this for about 6 months on him and it didn't work, so eventually we did go to surgery with him. But this does require an embolization preoperatively, which requires you to have interventional radiologists that are going to be comfortable doing this type of embolization, and this is a direct stick into the tumor itself rather than intravascular embolization followed by intralesional resection. So I know this was very quick, but this was just to kind of give you an overview and taste of the different types of tumors that you might be thinking about as far as when in the timeline of the whole treatment disease and what you might be thinking about in your practice if you're going to undertake these things. So it does take a village. You need to understand what the pathology is, if it's a primary tumor or if it's a med, exactly how you're going to treat it, when you're going to treat it, are there neoadjuvant therapies that you need to give like chemotherapy, radiation therapy, and where surgery is going to play a role in that. So I'll complete there and my jackets.
Please work your way up to a microphone if you have a question, and maybe I'll just start while that's happening. Impressive cases, gentlemen. It's a little bit daunting for me, and I presume for many in the crowd, to look at these. I want to explore a little bit more the philosophy of who should be doing these kind of cases, and how do you get experience, and how many are there of us that could really tackle these kind of things versus, and how many you need to do in a year to be comfortable and competent. You know, it's not something that I think many of us probably have much experience in, unlike you two. So can you talk a little bit about that? Each of you, maybe start Zia and then JP, you can.
Well, I think that the metastatic tumors are very common, and hence I think it's best that they be handled in many of local hospitals effectively. And for that, I think we need to really sort of communicate effectively to the people who are performing these procedures regularly, the general principles of how to approach these patients and how to address the problem at hand. And typically these tumors do not require advanced training. It doesn't really require having a lot of experience like we do in primary tumors. And hence I do feel that most spine surgeons should be well trained in taking care of patients with metastatic spine tumors in many of our local hospitals. And many of the patients will also be treated for their cancer locally in many situations. I think the primary tumors are very different. Not a lot of people will be able to gain enough experience to get comfortable understanding all general principles of how to treat these tumors, and furthermore, technically get comfortable to be able to pull these operations without any significant complications. And so for that reason, I think those cases would be best treated in larger centers where there's expertise and multidisciplinary teams. As JP shared here, you may have to do a intraoperative embolization. You may have to treat the patient with preoperative radiation treatment to optimize the results of the surgery and so forth. So it requires a multidisciplinary team and extensive discussion before taking the patient to the OR.
Thanks. JP, anything else to?
So, I mean, I think it's a question I struggle with all the time with the fellows, right? About when do you know that you can pull these things off, or when you want to pull these things off. And, one answer I give them is, number one, don't go to a fellowship where you're going to think you're going to come out being a primary tumor specialist, because there's not that many of them out there, and you probably would go broke waiting for those tumors to show up. But I think it also takes a lot of experience of just being comfortable with these. And I had the fortunate experience of my early years of professional life being teamed up with Zia. So you had somebody who had experience who could bring you along on that way, and you could run cases by or work together. And I think that's key to bring yourself up to that experience, because there just aren't enough of those cases. But I also would say that I think that's true for anything we do, whether or not it's primary tumors or degenerative spine. So physicians, surgeons that I see that do microdiscs very well are incredible at it. And they got that way because they did thousands of them, right? Luckily, there's thousands of microdiscs out there, but it does take a while for you to get to that level. And you're just talking about something now that's, instead of an hour operation, this is a 14-hour operation. So there's a lot of work hours in that to get to that level of comfort.
Great. Trey.
I'm going to jump in and ask a question, if I can, just change course a little bit here. So say we're in a hospital where we're not doing primary tumors on a regular basis, right? But we still get patients that come in, have a neurologic deficit, it's after hours. Getting a biopsy sounds like the thing we should do, but it's not really an option after hours. Or is there a role for proceeding with surgery without a biopsy? And one more question, if I can, because I'd like to know this too. Using steroids in that case and buying some time, is there anything else we can do other than steroids?
So coming back to your first question, first of all, I think it's very difficult to be dogmatic about these situations. You are in the front line, you're taking a patient who is at the verge of being quadriplegic or paraplegic, and you do what you think is in the best interest of the patient at that point. So I would never question, fault, or be critical of anybody who was taking care of a patient at 2 o'clock in the morning when I was not there, and they are making the decision to their best ability and taking care of the patient. So categorically, I think we should really refrain from being critical of other people who are in the front lines. And the message that I was trying to communicate in my talk was that you're almost, you're put in a position in many situations where the patient is fairly impaired neurologically. Imaging looks very concerning, and you think it's a tumor. Coming back to your comment related to steroids, in many situations, at least in my experience, you can temporize. You can put the patient on high-dose steroids, unless they've been on steroids and they've exhausted that route. But you can buy 2-3 days to yourself, and then in the meantime, maybe you can do a quick diagnostic workup and sort the things out. So sometimes I see with our fellows, they function in some situations independently. They take the patient 2 o'clock in the morning to the operating room because image looks very concerning. But in retrospect, you could have probably gotten away with just putting the patient on steroids and doing a biopsy, learning about the tumor, and then you can formulate a very thoughtful plan if you have all that information. And so, but I would never be critical of anybody who took the patient at 2 o'clock in the morning when the patient was about to be quadriplegic. This happens commonly with Ewing sarcoma, for example. Young kid is brought to the hospital, there's this horrific looking tumor, and the kid is about to become quadriplegic. Yes, I mean, you're going to do whatever needed to be done, and then you find out after the fact that the patient has Ewing's. Yeah, it would have been better if you had known about it and treated the kid with, multimodality chemo beforehand, but you don't have that information.
Just to kind of branch off of that same thing, so you're in a community hospital setting, and a patient comes in with a neurologic deficit, spinal tumor. There's a lot of evidence that no known primary, you do some sort of workup, is evidence that says that these patients do better when handled at big tertiary care centers as opposed to a community hospital. That's where they can get the care they need. Is it better for these patients to get some sort of workup and then tell them to, email your office? Is it a hospital-to-hospital transfer kind of thing? Like, what's the best route to get those patients care in a good manner, assuming it's not an emergency? Let's say it's couple days urgency.
So, I would say that the one good thing that happened out of COVID, maybe there's more than one good thing, but I think is the ability to have telemedicine, right, where we can actually get a hold of films and talk with patients, because that gives, with this whole thing of when to refer, there's another aspect of it too, right? It's not like every one of these patients does perfectly with us, right? That's not true. These tumors recur, and some of these patients do exceptionally poorly. But from a patient perspective, they're very happy with being referred to another center. That surgeon that referred that person is actually very happy because they realize they've just dodged a horrible bullet that's going to bother them forever. And so from a psychological perspective, it's very helpful for them. But I think for getting them into the system, you can do it by transferring. I think it's a little bit of a circus for patients, and it's a very big headache for patients' families, but so a direct hospital-to-hospital transfer is usually not necessary, but just emailing, calling, getting them into us is very easy, and now with telemedicine, we can respond to them pretty quickly, too, so they can at least understand that somebody's doing something rather than what used to happen, at least in my practice, where, if I'm actually getting some other colleague to see somebody, it might take them weeks for them to get the paperwork, but now it's pretty seamless, I'd say.